This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Welcome to Friday Fellows Conference. As our speaker this morning is Dr. Birju Rao, one of our third-year fellows in the clinical investigator track. Birju did his undergraduate studies at Northwestern and then medical school at the University of Illinois, Chicago. Was an internal medicine resident here at Emory. Did research with Dr. Dickert, and looks like he's going to talk to us today about AV block and syncope and device therapy. So take it away, Dr. Rao.
Thanks, Dr. Williams. All right, then thanks for the introduction. Yeah, as you mentioned, my talk is going to be sort of revolving around a case and an interesting discussion we had about someone I saw during my EP rotation at Clifton, and a discussion about interesting new or exciting new topics in cardiac devices for folks with AV block. These are my learning objectives. Three main big ones. One is review the differential for paroxysmal AV block. Two is to understand the role of conduction system pacing for patients with AV block. And then three is to review guideline-directed device recommendations with patients with cardiac sarcoid. So the patient story sort of starts first in the clinic. So he's a 58-year-old gentleman. He was sent as a new patient visit into EP clinic for a syncope evaluation, the setting of an abnormal EKG. So he initially, about a month ago, presented to a local emergency room for a drug rash or an allergic reaction, something unrelated. And on review of systems, they had found that he also mentioned, he's like, yeah, I've been having these spells where I was passing out. It's been going on for the past couple months. And then he had this EKG, which clearly shows right bundle branch block, left anterior fascicular block. I think the PR interval is right on the border, so it was coded as bifascicular block. In terms of his other history, he has no significant medical history. He has family history. He has a grandmother who died of an MI, a father with hypertension, no prior surgeries, no tobacco, alcohol, illicits. Interestingly, he's a chemist at Yerkes. In terms of additional sort of workup, his exam was completely normal, unremarkable. Lab work from the ED that was reviewed was also otherwise completely normal, other than isolated elevated alk phos, borderline right in the 137. And this is his chest x-ray. It looks okay, maybe just some fullness in the hilar regions. So a little bit more about his syncope history. He had sort of two frank syncopal episodes and then two pre-syncopal type episodes over the past several months. The first episode, he said, occurred while he was cooking at home. No prodrome, just completely lost consciousness, fell to the ground, and then was out for a couple seconds and rapidly regained consciousness. No post-ictal phase, no seizure-like activity again, and no prodrome to that. The second episode occurred, he said, while he was reading on his couch. He wasn't sure if he sort of nodded off and fell asleep, but he was out for, again, a couple seconds without rapid regaining of consciousness. And then he had these two sort of vague pre-syncopal episodes that were associated with lightheadedness. The more concerning one occurred as he was driving home. He was sort of felt lightheaded as he was pulling into his driveway and parking. So obviously very sort of concerning history in the setting of very abnormal EKG. He was clearly told not to drive until we finished the workup, which included an event monitor and cardiac MRI to rule out infiltrative processes given his young age. So, I think this case is an obvious one to restrict driving, but I was just curious as to, how we decide when and who to tell to how to restrict driving. And the literature is not, there's not high quality evidence to drive some of these recommendations. It seems like most of the recommendations are driven by local policies, regulations surrounding like the local DMV, what they say is needed based on different municipalities. And it varies, as you can imagine, widely based on where you live and what the local DMV says the restrictions are. Generally, it tends to be folks who have syncope should restrict driving for about some couple months, 6 months, something like that, which, seemed like a rule that was painted with broad strokes, because it wasn't, if someone comes in with a history that was really classic of vasovagal syncope, do they really need to stop driving for 6 months? It seems a little harsh. So this is a paper, probably one of the better quality papers that I had found looking at this. Again, it's still a retrospective study, cohort study of 10,000 patients in British Columbia with ER visits for syncope. So a little bit, probably a more significant syncope history. And they followed them to see over a year and saw how many of them actually had motor vehicle accidents. So it was kind of interesting. They used registry data. Canada is kind of like a contained system. So they saw who, based on looking at the driving records, who had ended up having any sort of motor vehicle accidents. And they compared them to a control group, which was a similarly matched population who also had ED visits, but for non-syncope reasons. And there was no main difference. You can see these Kaplan-Meier curves. There's no big difference between the syncope and the control group. Obviously, this is a lot of limitations of the study. It's observational study. You can have selection bias, et cetera, et cetera. One of the big, I think, limitations was we didn't really know what the clinician told the patient, whether they told them to restrict driving, whether they weren't restricted, what that deal was. But I think the way the authors spun it, and I think it's my takeaway from this paper too, is that probably the clinicians in this group probably used their best judgment as to telling if they felt that the patient had a concerning syncope history, they told them to stop driving. And if they weren't concerned, they probably didn't tell them to do that. And that's probably the right thing to do, just to use your clinical judgment. We probably don't need broader syncope rules to stop driving for all patients who have syncope. So just coming back to our case, the event monitor was placed, and again, this is an event monitor, so it's non-triggered activity, but this is 2 days into him wearing the event monitor, fairly concerning strips here. The first one is just it's a sinus arrest with a P wave without a corresponding QRS, but here we clearly have high-grade AV block with multiple P waves without QRS complexes. He got an urgent phone call. He said he was feeling fine, but we told him, you really need to come in to the hospital, be direct admitted for an expedited workup. So, this guy has heart block. So I figured it'd be a good idea to just go through the etiologies and the differentials for why someone would be having heart block. I've sort of separated it into several big buckets or categories of etiologies. The first one is congenitals, corrected transposition, large primum ASDs, large AV canals, essentially anything that can possibly interrupt the AV node or have any issues with the AV node from birth. Neonatal lupus can do it. The antibodies, lupus antibodies have a predilection for attacking the conduction system. There's this congenital AV block, which I had learned about during my EP rotation, which, patients are otherwise normal, have a structurally normal heart, but this gene that codes for, or the gene that's regulating the AV node has a missense mutation. So you just have heart block congenitally. Interestingly, the gene that codes for that is probably one of the more famous genes on cardiology boards. It's the SCN5A gene, which is also responsible for Brugada, long QT, some cardiomyopathies. I thought that was a little interesting. But just moving on in terms of etiologies, infectious, we're probably familiar with this. It's endocarditis with abscess, valve abscess, and then Lyme disease also falls under this category. Inflammatory and infiltrative. So this is things like sarcoid, amyloid, Hokum sometimes, some types of myocarditis can also do it. Interestingly, if you have myocarditis with AV block, it's a poor prognostic sign. And then in terms of infiltrative tumors that can infiltrate and sort of push on the AV node can cause heart block as well. By and far, the most common in the literature is defined as ischemic. So these are folks who either had a big posterior MI, heightened parasympathetic tone that's causing AV block, or folks who've had a big prox LED that knocks out the AV nodal branch going to the AV node here. This is a schematic diagram showing that can have heart block. There's this sort of degenerative picture of patients who have just progressive degenerative conduction system disease, and it's broken into these two diseases separated by age. So Lenigre and Leves disease. So Lenigre is a progressive fibrotic degeneration of the conduction system in folks younger than 60. And Leves is for the same sort of thing for folks greater than 70. And it's associated with severe MAC, calcification, the aortic root, those sorts of things that can interrupt and injure the AV node just based on proximity and anatomy. Metabolic and endocrine, this is stuff we're all trained to look for. Make sure the TSH is normal, make sure that the potassium is okay. NMD is neuromuscular disease. This is myotonic dystrophy, Duchenne's, Kearns-Sayre's. And iatrogenic, we do see this from time to time. Folks who've had open heart surgery and the surgeon accidentally puts a stitch through the AV node. TAVR, and folks who have, especially with folks who have an underlying right bundle, the TAVR valve knocks out the left and then causes AV block. Transcatheter VSD closure, the same sort of thing, can injure just based on proximity of where they're working, can injure the AV node. Alcohol septal ablation, and then obviously catheter ablation, whether it's intended or not. So this guy has high-grade AV block and needs some type of pacer. So what are her options here? So we have the sort of traditional pacemaker, which there's a lead in the RV apex, there's a lead in, or there's a lead in the right atrium. This is sort of the same strategy of pacing that's since when pacing was developed in the 1950s when the surgeons were doing it. Obviously, there have been iterative improvements. The can gets a little smaller, the leads are better, technology's improved, but essentially the same principle of pacemaker. I don't have this pictured here, but there's another option where a micro, which is the leadless pacemaker, which is the same sort of principle, except there's no can or no wire. You just have the whole system goes here into the RV apex and then paces the patient from the RV. And now there's this emerging strategy of conduction system pacing, which in which like the pacemaker leads are attempting to directly engage into the body's natural conduction system to generate a more physiologic type of pacing. Theoretically, this strategy allows for better RV and LV synchrony without needing continuous resynchronization system. So without needing a CRT and an LV lead, you can try to accomplish this. Areas where conduction system pacing can be useful. So the first three are areas where a patient needs a resynchronization therapy anyways. They need a CRT. So either they've had an AV node ablation, they need a CRT. They need a CRT and they're unable to do it. There's no suitable side branches to park the LV lead. And again, desynchrony, if you have a wide left bundle that causes cardiomyopathy, you need resynchronization therapy. And then there's this other category, which we'll talk about some, is patients with AV block and high pacing needs. To prevent pacemaker cardiomyopathy, how can we do more physiologic pacing? And this is sort of just, I wanted to give you a picture of what this looks like. Creates a really pretty EKG. So the top one is a case report of a gentleman who had a wide left bundle, had cardiomyopathy. And then at the bottom, they put a conduction system pacer in, and you can see the QRSs are nice and narrow, especially in the lateral precordial leads. They almost look like his native conduction if you didn't notice the pacer spike, which makes sense because you're engaging the actual conduction systems. You're doing it in a more physiologic way. So this figure sort of shows there's a whole variety of ways you can do conduction system pacing. Anywhere along this area from the AV node down the conduction system. Just to orient everyone, that this is sort of where the right atrium would be. This is where the right ventricle would be. This is the septum, the AV node going, and then the left and right bundles going down, separating after the His. The two main types of strategies that I'm going to focus this talk on are His bundle pacing and left bundle branch area pacing. These are by and far the most commonly described in the literature, and probably the most common types of conduction system pacing done clinically. So His bundle pacing is where the RV lead is put in directly into the His bundle right here, is screwed, right into the His bundle. And then left bundle branch area pacing is you take your RV lead and screw it into the septum, somewhere in the septum, to try to capture the left bundle. There are some pros and cons of each. I'll go through those a little bit more in depth, but just superficially, His bundle pacing is a little bit more technically challenging because you have a smaller landing zone, a smaller target to get your lead into. It has also a little bit more challenging to manage those devices, as I'll talk about a little bit, but the anatomy of the His is such that it's encased in this fibrous tissue. And when leads are screwed into the His, it causes this fibrotic reaction, which can increase thresholds, cause early depletion of battery life, and can sometimes even cause failure to capture. And then obviously with His bundle pacing, if the lesion is distal to the His bundle, pacing from here won't really be super helpful. So if someone has infrahissine disease, if they have a left bundle, if they have other disease downstream, then when you're pacing from here, it's going to block, and it's not going to be an effective strategy to physiologically pace the patient. And then the left bundle branch area pacing, as you can probably imagine, there's a bigger landing zone. You sort of generally need to get it into this area to get capture of the left bundle. These have a little bit higher success rates and lower thresholds compared to the His bundle pacing. This slide is just to reiterate what I had mentioned previously. So this is, when we're looking right here, these are your two options for placing a His bundle pacer. But for left bundle branch area pacer, you have a lot of places where you can try to capture the left bundle here. Just wanted to go through some of the basic anatomy and landmarks for understanding where the His is and how folks sort of orient themselves and figure out where they are in the lab. So this is an imaginary triangle. It's anatomically important. It's called the triangle of Koch, which is on one side bordered by the tricuspid valve annulus. On the other side, it's bordered by this tendon of Todoro, which connects here to the AV node and extends down into the right atrium, right under the fossa vallis. And then the third side of the triangle is an imaginary side, which is bordered by the coronary sinus os. The important thing here is that the His bundle, which is right here, begins from AV nodal tissue and then courses down across the membranous septum in the right atrium before penetrating on the left side of the crest of the muscular portion of the intraventricular septum. So, and as I mentioned before, the His it's encased in this fibrous connective tissue rather than myocardium. And then it sort of enters the muscular septum and separates into these two bundle branches. So, a little bit of history surrounding this conduction system pacing. This is sort of the new kid on the block and everyone's talking about this. But this idea of using the conduction system to create a more physiologic electromechanical conduction really isn't new. So this is a paper by the one and only Carl Wiggers of the Wiggers diagram in 1925. And it's like 40 pages, a behemoth of a paper of just basic science physiology. After just reading through it, I just want to sort of briefly summarize it. This paper really creates the foundation for what we today describe as electromechanical uncoupling, where when you're pacing one side or when you're using any sort of non-physiologic pacing, it creates this dyssynchrony in where you have a delay between the activation of the RV and delay and activation of the LV, which can cause issues. So just three main, very simple takeaways from this paper are: one, pacing at virtually any ventricular site disturbs the natural pattern of activation and contraction, because the evoked electrical wave fronts propagate slowly through the myocardium rather than fast if you're going down the His-Purkinje system. This second, this altered ventricular activation causes immediate reduction in pump function. And then the last point was essentially, Dr. Wigger shows that in general, pacing in the RV is worse than pacing in the LV. And the worst place to pace in the RV is the apex. So this paper has come out a long time ago, but still for many years, this was the mainstay of pacing, was to do this through the RV. So, clinically, on the basic science and animal model side, people have been trying to do conduction system pacing for a while on dogs and different animals. But Pramod Deshmukh in 2000 really did the first clinical, rigorous, systematic attempt at doing this in human beings, where he publishes this case series of 18 patients with chronic AFib, a narrow QRS, and LV function needing sort of an AV nodal ablation, the CRT implant. He demonstrated a feasibility of implanting a transvenous system with a lead directly into the His bundle. Out of the 18 patients, he was able to successfully do this in 12 patients, with a subsequent decrease in those 12 patients in the LVEF and an improvement in their cardiac function. Improvement in the LVEF and improvement in their cardiac function. So just to go through a little bit of the how this is done in the EP lab and sort of trying to blend the anatomy that we talked about into this fluoro image here. So just a little bit of background. So this is a patient who had a mitral angioplasty and then needed a pacemaker and had sort of a single chamber pacemaker that was put in. Then he was chronically being paced and needed a device upgrade because he developed LV dysfunction. So just to orient ourselves, this is sort of where the atrium is. This is the ventricle. This sort of circle that they've outlined here is the coronary sinus. This is the AV node, and this little blush of contrast, as they push here, is the tricuspid valve annulus. So you can sort of create your own imaginary tendon of Todoro here and create a triangle of Koch to sort of understand where we are. And this is the AV node, and this is the His bundle. So this is the catheter or the pacemaker lead that's trying to sort of deflect upward and get into this His bundle. As you can probably tell, it's not very straightforward. Anyone who's done cath rotation can see that, to get this to push up and direct upwards this way is not the easiest thing. And the His is also a very small target. So localizing the His, I don't want to get too crazy with electrograms here, but the one thing I wanted to show, which I thought was kind of cool or neat, was this at the tip of the electrode here. You can see that they're at the proximal His bundle because you see a nice His deflection, an A and an H deflection. But when you are in the distal His, on the far side of the His, which is generally where they place the lead, the His signal is much smaller and much more difficult to sort of identify and figure out you're the exact right place. Again, just to demonstrate that this is sort of technically challenging procedure. So at least from the technical aspect, we can see that His bundle pacing is a little bit more challenging than just planting a lead in the LV apex. There's also been literature to describe the increased thresholds I've mentioned in His bundle leads because of that can cause early battery depletion or even failure to capture because of this fibrosis that occurs. And lastly, if there's infrahisian disease, His bundle pacing really doesn't work super well. So to try to address these issues, people searched for somewhere else that we can screw in our RV lead to also still create physiologic pacing. The first case report of left bundle branch area pacing was described by Dr. Ellenbogen, who's kind of like the Hearst of pacing. He has the big textbook. He's a big name in the field at VCU. And this is a gentleman, a 72-year-old, or actually a female, a 72-year-old female with a left bundle branch block and heart failure, needing a CRT, but they were unable to get into this to the CS to place the LV lead. So they mapped figured out where the area of block in the left bundle branch block was and paced it distal to the side of the block. So you can see, just to orient ourselves a little bit to the anatomy here, this is the pacing wire coming in, making this turn. This is the RV septum. You can see they pushed a little contrast here, and you can see the blush, the contrast across the septum. And they're screwing this lead straight into the septum. And on echo, you can actually see, I mean, there's like almost like a tip of the septum, the tip of the lead is almost in the actual LV cavity. Patient did well, and they had no heart failure hospitalizations a year after, and their LVEF improved. So again, just correlating our anatomy discussion with what's seen in fluoro, just to show how much easier this is compared to His bundle pacer. So this is generally where the His is. Again, this is the sheath, the wire that's coming through here. And this is our area, our target area, this huge, a relatively big area where we can put in the left bundle branch area lead. And this is the RV apex. So this just, again, to show a little bit easier in terms of identifying and getting to where we need to go. So just going through pros and cons of a traditional pacemaker versus a conduction system pacemaker. So the pros of the traditional pacemaker, obviously, it's fast, it's reliable, it's the tried and true method. The cons are obviously, chronic RV pacing can lead sometimes to pacemaker-induced cardiomyopathy due to desynchrony. And then the other con is if someone, for example, needs a CRT, needs an LV lead, sometimes that can be challenging to get into either the CS or get into the CS, but there's no suitable side branches to plant your lead, and then you can't get the lead exactly where you want to capture the LV. In terms of conduction system pacing, the pros are it's more physiologic pacing, and potentially when you compare it to like a CRT, it's potentially less leads because you don't need that extra LV lead. The cons are obviously depending on what type of procedure they do, what type of conduction system pacing strategy they use, and how comfortable or how sort of facile the operator is. It can be longer procedure times, longer fluoro times. It can be technically more challenging. There is a higher risk of procedural risk sometimes of dislodgement or perforation, especially with that left bundle branch area lead. It's, as you saw in the case report, it's really screwed into the septum, almost butting into the LV. I mentioned this a couple of times, is loss of capture due to fibrosis with His bundle pacing, and higher thresholds. And obviously it takes longer time, and it requires more fluoro, but it's still compensated the same way as a traditional pacemaker. So I think up until now, I've talked about a lot about how physiologic pacing has been there to try to address electromechanical uncoupling, but I wanted to just jump into some of the literature to describe the specifics of how and when this sort of desynchrony becomes an issue. Because as we know, we all, I'm sure, know patients who have regular old school pacemakers and they don't have any issues with it. They're doing just fine. So the first trial I wanted to talk about was the David trial in 2000, came out in 2002. Apologies for the grainy pictures here, but essentially the David trial was a multi-center RCT, which wanted to answer the question, which is better, dual chamber pacing or backup pacing. So the two pacing strategies were these patients all, this is like, I think 500 patients with cardiomyopathy, LVEF less than 40, who all had secondary prevention ICDs. And they were randomized to one of two each to different pacing strategies. So one of their ICDs was set the way these days normal ICDs are set, with a backup pacemaker at VVI 40. So just to make sure you don't go super bradycardic, the ICDs there to just protect you from going super slow. The other group was pacing at DDD 70, so pacing at a higher or sort of a little bit higher than the normal rate actively. And the inherent hypothesis here was that pacing at this rate of 70 would provide a rate support to increase the cardiac output for these heart failure patients, suppress ventricular and atrial arrhythmias, and then permit increases in beta blockers and help facilitate a GDMT titration. The primary endpoint in this trial was a composite of all-cause mortality and heart failure hospitalizations. The trial was stopped at 1 year by the DSMB because there was a dramatic increase in mortality in the group that was having this dual chamber pacing. It was being paced at a higher rate. There was almost, I think, a 10% absolute increase in mortality in that group. So they had to stop the trial. And, you know, a lot of the results here were not super powered to detect a lot of these differences. But the main point and main takeaway here was that active pacing, particularly active pacing in the RV, is bad. Causes worsening heart failure hospitalizations, causes a deterioration in the EF, and increased mortality. So then the next question is, okay, chronic RV pacing is bad. How much is too much? So a subgroup analysis of this trial, the MOST trial, really answered that question. So the MOST trial compared essentially dual chamber pacing to regular ventricular pacing. Didn't find any difference in heart outcomes, but it was found that dual chamber pacing in the A and in the V, using that sort of pacing strategy improved quality of life, prevented AFib, prevented and reduced heart failure hospitalizations. So a subgroup analysis of that trial looked at two groups, one where pacing was done at greater than 40%. So this group had a greater than 40% pacing burden, and this group had a less than 40% pacing burden. And this is an event-free Kaplan-Meier curve. So if you think about it, it's a sort of a survival type curve. The folks who had more pacing, greater than 40%, did worse. And the event that they were looking for was heart failure hospitalizations. So because of this trial, the answer to this question, how much is too much, has become 40%. The other thing is that abnormal baseline cardiac function can also predispose you to developing pacemaker-induced cardiomyopathy. So that was sort of found by this trial, the Block HF trial, in which they compared BiV pacing compared to RV only pacing. So this is a group that had they all had LVEF less than 50, and they all also had heart block. And all of these patients had BiV systems implanted. And with the BiV systems both implanted, one group, the BiV sort of pacing was turned off, and it was just, the device was just treated like a regular RV pacemaker. And then the other group, where the BiV system was turned on, they were getting synchronized cardiac resynchronization therapy. The primary endpoint is this sort of strange composite. I'm not sure why they did it like this, but the primary endpoint was all-cause mortality plus heart failure hospitalizations plus a 15% increase in the LV end-systolic volume index. Here, as you can see, folks who were in the CRT arm did much better than compared to just the RV pacing arm. And this was still, even this difference was still even at the expense of a very high complication rate, particularly a good number of these complications, procedural complications, were related to LV leads. So add this, and again, the average EF in both these groups was around 40%. And the NYHA class was around 2 in both of these groups too. So this sort of helped demonstrate that if you have an abnormal or mild moderately reduced LVEF, you're at risk for developing pacemaker-induced cardiomyopathy if you're just being paced in the RV. So I think we've sort of laid out a lot of issues, a lot of the issues that are related to chronic RV pacing. But sometimes the alternative, which is putting an LV lead in and doing cardiac resynchronization therapy, that always isn't great too, as we saw, here in this trial, pretty high complication rate. Many of them were due to difficulty getting the LV lead in. So those are really the things that conduction system pacing really needs to solve. So I'm going to try to now move on to present some real world data related to conduction system pacing outcomes. Most of the high quality conduction system pacing data comes in the CRT space. So the best comparison group here is patients who have CRTs, and then you're using conduction system pacing to compare which is better or whether they're about the same, et cetera. So this trial was done 2022, a multi-center randomized controlled trial called the LBBB Resync trial. I sort of put it, it's a pilot trial really, because it's small, N of 40, and they're randomized 1-to-1 to either receiving a conduction system pacing device or like a traditional CRT device. These are all patients with non-ischemic cardiomyopathy in the left bundle needing cardiac resynchronization therapy. They were randomized 1-to-1, having either a lead put in the left bundle here or around the left bundle, or you have your resynchronization therapy, an LV lead and an RV lead. There was essentially a statistically significant improvement in LVEF in the left bundle branch pacing arm, but no major differences in hard outcomes. I think the thing that I thought was particularly interesting about the trial is, they looked at it with an intention to treat model, but when you look at the per protocol analysis, there were 4 patients who were randomized to the CRT arm, the usual standard of care, and 4 of those crossed over from the CRT into the left bundle branch pacing group, primarily because sometimes it can be difficult to do if sometimes patients' anatomy is not suitable for that. So this sort of shows, 1, the feasibility of this, and 2, that particularly for CRT bailout, when you're unable to get a good result with a CRT, a left bundle branch area pacemaker, which is a little easier, may be a good option here. So this is a little bit bigger study, observational though, comparing conduction system pacing. This is both left bundle branch area or his bundle. They left it sort of up to the discretion of the operator, whatever they felt comfortable doing, comparing that to CRT. And there was a reduction in heart failure hospitalizations in the CRT arm, almost like a 10% reduction, and improvement. Some folks who also had improvements in the QRS and LVEF improvements in both groups. So again, this is retrospective data, but also still just demonstrates that conduction system pacing can be a good alternative to CRT. And this is a trial that sort of mentions or highlights what I had mentioned in the first paper that I mentioned, that we talked about, where conduction system pacing can be a good option for a bailout procedure if you can't get, or if you feel like you can't get a good result with a CRT. Here it was 212 patients who failed CRT, and then they underwent attempted left bundle branch pacing. It was successful in 91% of the patients. Their sort of primary outcome was a strange outcome where LVEF above 5%. or improvement in the LV of about 5%. So they did meet their outcome, but they had this super response group where some folks had a complete normalization or sort of very significant improvement in their LVEF after getting a physiologic pacemaker put in. So really exciting work in this space. But again, where are the RCTs? Where's the great quality data? Well, it's coming. There is a $2 million PCORI-funded multi-center randomized controlled trial looking to answer this question of CRT versus conduction system pacing in heart failure. And again, they're leaving it, I sort of mentioned the 2 conduction system pacing strategies, but they left it open to whatever people feel comfortable doing, whether if they feel more comfortable doing HIS or they feel more comfortable doing left bundle branch area pacing, whichever, comparing the 2. And I think it's still in the process of getting started here, but this will give us better data in terms of seeing whether this is a real alternative to real alternative, or maybe even better than CRT, which is the standard of care. So a big segue here, but just getting back to our case, the gentleman with heart block who was admitted got a cardiac MRI looking for infiltrative processes, and lo and behold, we found here delayed gadolinium enhancement. These are also representative pictures, which with nicer arrows. I can show you exactly sort of where the delayed gadolinium enhancement was. So when we called the radiologist or the cardiac imager, they'd said that this is sort of very characteristic of cardiac sarcoid, especially given the clinical context. There were also some additional non-cardiac findings, which helped cinch a little bit of the diagnosis too. So we had some osseous lesions in the spine, which sarcoid can do, and may explain, if you remember, the slightly elevated alkaline phosphatase and the enlarged pulmonary lymph nodes, which we saw a little bit of hilar fullness on the chest X-ray, bringing it all together for a new diagnosis of sarcoid with cardiac involvement in this patient. Just briefly, I know Ariel had already sort of talked about sarcoid at length, so I won't beat this over your guys' head, but just what I thought was interesting was, the imaging findings. There's a whole spectrum of imaging findings where you can, at this end of the spectrum, if there's no delayed gadolinium enhancements, almost sort of rules out sarcoid. If you have multifocal delayed gadolinium enhancement, particularly the insertion of septum into the RV, it's very characteristic, almost certainly sarcoid. And then you're sort of sometimes in this gray zone where you use your Bayesian pretest probability of what we think the patient is to hopefully try to impact things. But sometimes you're stuck with some of these middle categories. Luckily, in this patient, we had a diagnosis and we were able to proceed further with getting him better. Pathological diagnosis of sarcoid, as you guys can probably know, is challenging just due to the low yield of biopsy. In recent years, with high quality cardiac MR and PET, that's sort of become now the mainstay of trying to diagnose sarcoid. Main strength of delayed gadolinium enhancement in cardiac MRI is early detection. High sensitivity. Also, delayed gadolinium enhancement is associated with an odds ratio of 10 for increase of ventricular arrhythmias and all-cause mortality. So that's really important when we're thinking about risk stratifying these patients. Just going through a little bit, I don't want to belabor this slide too much, but there are multiple diagnostic criteria for diagnosing cardiac sarcoid. Main ones, both of them are advanced AV block, where you really want to consider, does this patient have sarcoid or not? And the treatment of cardiac sarcoid mostly revolves around immunosuppression. There's not great quality of data on how to systematically do this. You can use glucocorticoids, methotrexate, TNF-alpha inhibitors, obviously device therapy, sort of focused on what the patient's lesion is, whether it's VT, whether it's heart block. And if they have nothing, then the sort of primary prevention device space becomes a little challenging, which I'll talk about in the subsequent slides. If the patient has VT, there's not great outcomes with catheter ablation. And we've seen this a couple of times where the patients have end-stage cardiac sarcoid and they're being listed for transplant. So this slide I kind of wanted to just quickly go through the patient, not necessarily pertaining to our patient specifically, but if you're ignoring all of this, go down, this patient already has AV block, and then they need a pacemaker. So just going through the diagnostic schema, this is the HRS sort of diagnostic guidelines on how to think about this. So do they have an LVEF less than 35? If yes, then they need GDMT. But do they have infrequent pacing? So if someone has infrequent pacing, insignificant comorbidities, if this patient had very intermittent heart block and you think that they're not going to really require their pacemaker that much, and they're 90 years old and have cancer, et cetera, they have a lot of other things going on, a single chamber pacemaker, a micro may be a reasonable option here. Do they have permanent AFib? If they have permanent AFib, there's no point of putting a lead in or permanent AFib. Yeah, there's no point of putting a lead in the atria. If they don't, then dual chamber pacing is indicated based on the trials that we sort of talked about. And now this is sort of interesting. They say, does this person have an LVEF greater than 50? If so, reasonable, just put in a regular traditional pacemaker. If not, then pacemaker or predicted pacing less than 40%. If not, then you could put in a regular pacemaker. If yes to both of if you think that both the LVEF is low and you're going to have a high pacing need, even the guidelines they mention HIS bundle pacing because it's the oldest and there's the most data around it, but some type of conduction system pacing may be indicated here. And we saw the trial data to see where they got these numbers of 40% and 50% based on the trials that I had mentioned. So I just thought that was kind of interesting here. Obviously in our patient, he had AV block, but also had sarcoid. So he earned himself a device. So he just needed to get an ICD rather than a traditional pacemaker because he had delayed gadolinium enhancement and had high risk features for VT. If this patient did not have a pacing need, then the question of when to implant a primary prevention ICD in him becomes a little bit more challenging in terms of helping you use all the data you have to try to risk stratify these people. And this is a chart that the guidelines sort of give us, help us risk stratify folks for arrhythmic sudden cardiac death. So obviously if they have a low EF, they earn themselves a primary prevention ICD. If the LVEF is normal, but they have extensive delayed gadolinium enhancement and scar on cardiac MRI, it's 2A to put it in ICD. It's reasonable to consider putting a primary prevention ICD in. And again, if you're somewhere in the middle, that's a tough call. You have to use the best judgment. And then there's also even some controversy regarding these guidelines. I saw this paper here that sort of criticized some of the data upon which these guidelines were made, specifically related to risk of ventricular arrhythmias. Most of the studies that they looked at the patients with cardiac sarcoid, the risk of sudden death, were single center, retrospective, obviously. Confidence intervals around the odds ratios were very wide. There's little data on how many of those deaths in those studies were actually due to arrhythmic sudden death, as opposed to sudden death from pump failure or other things. And it can be estimated that the annual risk of VT in these groups were 1.5% based on these meta-analyses. But this is in marked contrast to like population-based studies where you look at folks who've had cardiac sarcoid have devices in. The rate of VT in them is relatively low. And this is obviously a Taiwanese population, but it begs the question, is the data that we have really accurate? Just following up on our patient, as I mentioned, he had AV block, but also had cardiac sarcoid with delayed enhancement, risk of sudden cardiac death. So he ended up getting a traditional dual chamber pacemaker with discharge with a good result. His mediastinal lymphadenopathy was also noted on the cardiac MRI, so he was sent to pulmonology. who, this is the picture from the poem note, but essentially they talked to him about immunosuppression and try to get like more pathological diagnosis, but they felt that the risks of both immunosuppression, getting a lymph node biopsy outweighed the benefits. They sort of opted to treat him conservatively and put him on active surveillance. His AV block, unfortunately, has now worsened, and now he's 100% paced. But again, he has a normal LVEF, so hopefully he won't have a deterioration in his cardiac function. So in summary, a couple things that hopefully we learned here through this talk is that one, chronic RV pacing can lead to ventricular dysfunction. The two big risk factors for that is an LVEF, a low LVEF, and if you have frequent pacing needs. To try to address some of these issues, their conduction system pacing has sort of gotten more and more popular. And there's two big types of conduction system pacing strategies. There's the His bundle pacing, and there's left bundle branch area pacing. There's real promise and physiologic plausibility that this is going to be really great. There's promising early data, particularly when you consider those who need a CRT device. Given our patient had imaging findings for sarcoidosis, he ended up getting an ICD. And in the absence of AV block, as we mentioned, sudden cardiac death risk stratification is hard in patients with sarcoid. And unfortunately, as of yet, there is no great data on using conduction system pacing to prevent pacemaker cardiomyopathy. But hopefully, as conduction system pacing, as it's compared to CRT, the next phase will be to how to prevent pacemaker cardiomyopathy in folks who have frequent pacing needs. And the big question sort of I was left with at the end of this case, and the end of researching this talk is, is conduction system pacing, will it be, is it a fad, or will it become the standard of care? Again, a lot of the data that I showed you was observational. The randomized data was quite small. So there is a big randomized controlled trial coming down the line. Hopefully that'll help answer this question. And then how does the relative risk of arrhythmic sudden cardiac death compared to non-sudden cardiac death for patients with sarcoid? And then how does that impact ICD decisions? Again, these are nuanced discussions, probably not great for broad strokes with guidelines, but probably individualized to the patient, the risk factors, and what else is going on with them. In terms of conduction system pacing, hopefully better tools will help reduce procedure timing, procedure times and complications. And then better data will allow us to understand, like, is all this effort to try to do this, is the juice worth the squeeze? Are we gonna actually get a real benefit, hard outcomes with this? Like to thank Dr. Westerman, whose patient this was, and helped generate the discussion during my EP rotation about conduction system pacing. Appreciate Dr. Hirsch for his feedback on my presentation. Open to taking questions. Thank you for your time.
Thanks, Birju. Yeah, that was a good Freudian slip nickname for Dr. Hirsch. Feedback. Might stick. A couple like clarifications about conduction system pacing, and I'm sorry if you had covered this and I had sort of missed it. But so in terms of the procedure, in terms of the location, is it more based on QRS width? Is that sort of how they determine, like, sort of, again, and then this, to me, it sort of seems like CRT light at this point, or is this something that would also be used in sort of in conjunction with CRT for those that already have known, wide QRS and heart failure?
Yeah, so to answer your first question, I think the way they localize for His bundle pacing, I think they use, but just because it's technically challenging to figure out exactly anatomically whether you're in the perfect spot. From what I understand, they use both like EMGs and fluoro to figure out exactly where they are. Yeah. For this left bundle branch area pacing, I think they get into this general vicinity and just jam the lead into the septum and screw it in and get capture, and hopefully the QRS narrows. In terms of your second question, yeah. So this right now, I think this idea of physiologic pacing, the way to best test it right now is to compare it to CRT, because the value proposition is great there. It's like what you mentioned, it's CRT light. You have one less lead. CRT often it can be challenging. So this is the best way to get this moved forward, is to compare it to CRT. There's not great data in terms of preventing pacemaker cardiomyopathy, but hopefully as the data gets better, that'll come down the line. The physiologic plausibility is there that if you're using the conduction system to pace, it's probably going to help prevent asynchrony and help prevent deterioration of the cardiac function.
Well, great, thanks. Other questions from the group?
Stan Sherman, just has there been any data? I mean, we're dealing with sarcoid and it's an infiltrative disease.
Yeah.
And so, you probably don't want to put a pacer wire somewhere where the sarcoid is. That the idea that, you may have a more likely problem of pacing at some point along the line because of the infiltrative disease. And I did see some sarcoid, I think, on your slides on the right ventricle. And yet we put in a right ventricular lead where maybe this is an ideal patient with a septal lead, where I don't think we saw any sarcoid in the septum. So has there been any discussion on any of that, or any on any of the papers or anything?
Not to my not in the literature that I reviewed, but I think it's a good point. I'll have to talk to Dr. Lloyd and Dr. West and get back to you. I think it's a good point that it makes sense that if you have some active disease in there, it's probably not the best place to screw a lead into.
All right, any other questions? All right, well, thanks, Birju. An interesting topic and a new area to sort of pay attention to moving forward. And thanks to everyone for tuning in. Have a happy Friday, and we'll see everybody next week.
The preceding program is copyrighted by Emory University.